a few issues on invasive bladder cancer, starting with a discussion about cystectomy in the elderly. And I'd like to invite Dr. Droller and maybe represent the attitude in the United States to cystectomy in the elderly. Dr. Droller, please.
Thank you. A group of us were asked to discuss cystectomy in the elderly in our respective areas in the world. In North America, since 1970, the mean life expectancy has increased from 68 to 81 years in white men, 73 to 84 years in white women. And there have also been enhancements in organ-specific health care applied to enhancements in peri-operative care. But there is also, as we age, an underlying deterioration in physiologic function that may compromise treatment success and life expectancy in the context of treatment stress, treatment intolerance, and treatment complications. There's also not only a decrease in physiologic function, but a decrease in physiologic reserve that may compromise recoverability and treatment success and affect the quality of life. And it is important that when we think about the treatments available, especially with cystectomy and whatever neoadjuvant or adjuvant treatment we have, that these should be put in the context of disease prognosis in the different forms of bladder cancer and its treatment. Now also, age is an independent risk factor for the development of urothelial bladder cancer. Patients older than 65 have an 11-fold increase in cancer incidence in general and a 15-fold increase in cancer mortality. With urothelial bladder cancer, we see 28.6% in patients less than 65 and 71.4% in patients older than 65. So how do we look at cystectomy in the elderly? Well, first, what is the definition of elderly? One is chronological with changes in life expectancy, but I think more important is functional, the physiologic deterioration and the decreased physiologic reserve. And so this concept of elderly needs to be placed in the context of disease and in the context of treatment. Age is independently associated with in-hospital mortality and increased risk of complications after cystectomy. The elderly have compromised nutritional and immunologic status, which affects their ability to tolerate treatment and recoverability from complications. There is no significant difference in disease-specific survival, but overall survival is less in the elderly. Age and age-adjusted Charlson comorbidity index is associated with in-hospital mortality, risk of readmission, and worse overall survival. Alternative approaches to cystectomy are unlikely for the most part to provide a cure and may only temporize so-called disease-free survival or quality of life survival. And the trade-off between life years gained versus quality of life may be different from the perspective of the elderly versus the young. Every 10-year increase in age increases the adjusted risk of having at least one complication by 30%. A higher rate of complications is seen in octogenarians. A higher rate of early complications may be related to the higher rate of comorbidities in the elderly. And despite the equivalence of adverse outcomes in tertiary care centers, cystectomy is underutilized in octogenarians. Most patients in North America with muscle-invasive bladder cancer never undergo cystectomy. Selection, for various reasons, plays a major role. Elderly patients are primarily offered ileal conduit versus a neobladder because of the trend towards more complications with neobladder and other factors. Physiologic pressures of urinary diversion necessitate a choice in the context of physiologic capabilities, reserve, and comorbidities. The choice of urinary diversion is also influenced by considerations of management capabilities of the form of urinary diversion. Time and complexity influence anesthesia time, adequacy of healing, risk of complications, and ultimately successful functioning. So in summary, in terms of age-related treatment of bladder cancer in the elderly, detailed and broad perspectives are needed in making decisions on and planning treatments for this population group. These include an understanding of the comorbid conditions, their physiologic reserve, their loss of functional reserve, the risks of side effects and toxicities, their tolerance and response capabilities to treatment, their ability to recover reasonable levels of function and restore the quality of life which treatments can affect very seriously, a context of life expectancy as it may influence life expectancy, and then the costs, both personal and financial, relative to the benefits we see. Thank you.
Thank you, Dr. Droller. I'll ask Dr. Navarrete from Spain to give his perspective. There was one piece of information that was amazing. Only 55% of patients with invasive bladder cancer in their 50s are undergoing cystectomy. What happened to the rest of them?
Lots of delays, and then they're found to have metastatic disease. I think it's higher than 50%, but it's a surprisingly large number that do not.
Please.
Okay, my gratitude for this invitation. My comments are related with this work that we published in '82 in the British Journal of Urology, that was at that time the most important series in the world of bladder tumors, 1,744 cases. And I compare what we did in 1982, what now is happening in Europe. That study included something like 800 patients retrospectively and 900 prospectively. I want to insist that, of course, we discuss what was the main issue of discussion at that time in bladder tumor, looking for the natural history of this complicated tumor, including that famous classification of staging to be or not to be proposed by Jewitt. Cytology for us was very important, and we still consider that cytology of malignant cells, positive of malignant cells, is more discriminative than histology in bladder tumors. Indication for cystectomy in the elderly, I have to say the elderly in the UK means 70 years of age or older, and I don't like this title. I prefer to talk about senior adult, as John Fitzpatrick proposed many times. The technique at that time was simple cystectomy. Indication in the elderly was mostly palliative, 80% repeat of severe hematuria, obstructed uremia. Bladder substitution in our institution was always Woodwin technique. Neoadjuvant therapy assist at that time was radiotherapy, adjuvant therapy, radiotherapy also. There was no other possibility. I'm talking about '82. And alternatives to save the bladder was partial cystectomy, and there was several studies on radiotherapy. Now in Europe, most of the important things you can find in the guidelines of the European Urological Association, but I summarize here what is going on. So there are thousands of cystectomy per year, and we in Spain we collect from 2011 2,677 cases from 224 institutions. That means that there are many institutions doing less than 40 cystectomy per year. Indications in the elderly, now, of course, we have more curative intent, 80%, but continue with palliative intent, always for the same reason, mainly repeated severe hematuria. Technique, now we are discussing open versus laparoscopic, radical, including lymph nodes, in all cases, I believe, preserving the prostate apex and nerve sparing, this most common discussion on the cystectomy. Urine diversion today is more popular in the breaker than the ureterosigmoidostomy that we are still using, and we believe in ureterosigmoidostomy because with the knowledge we have today, you can overcome the early complication. Bladder substitution, many proposals, as you know. Most common use in Spain is Tudor. No adjuvant therapy. Yes, we have chemotherapy, adjuvant therapy, chemotherapy, and alternatives now are chemotherapy. And of course, I am not going to explain what the result of these studies. Mortality. Mortality in this study that I refer of 2,677 cystectomy, post-op mortality is 4.5%, mortality at 90 days is 5.7%, and 90% related with or urinary diversion complication, mainly. So the cystectomy is well tolerated, the urinary diversion is the complication. And now I show you my last radical cystectomy with the Goodwin technique, which is the spheric ileal bladder. I believe that you don't need any chimney for control reflux if you have a good spheric bladder. Upper tract, this is 6 weeks after the operation. Upper tract is perfectly draining, and this is a real spheric bladder. Thank you.
Thank you very much, Dr. Navarrete. Do you have an age limit for autotopic reconstruction?
In general, yes. We have an age limit, but maybe 76 is not the oldest patient we have used for bladder substitution. We have older patients than 76 years. People with 76 years today is younger people. That's my case.
Okay, thank you. Next is Dr. Zlotta.
So I hope we're not depriving you from the lunch. I kind of remember 20 years ago, if I were to say that I'm going to operate on someone who's 85, 86 that drowns, people would look at me, Zlotta, you're completely nuts once again. Now, honestly speaking, the number of patients, yeah, Lori, I'm nuts anyway, but I knew that. But now, the number of times where we have a discussion with a patient where I have to look twice at his date of birth before realizing his age, and where his only concern is whether and when he can resume golfing, 83, 84, 85. I think we all share the same view, is that the last 20 years have seen not only an improvement, general improvement, but the patients are just not the same patients as 20, 25 years ago. The second thing here is that it also depends a little bit where you are. In Toronto, I just heard that the size of Israel is 8.2 million. So Toronto is 5 million, 7.5 with the GTA, one single university, which means that the referral pattern and the way that these patients will be dealt with way less urologists spread out over the surface. Even if you look at the Toronto Multidisciplinary Bladder Cancer Clinic, where we see many, many complex cases, you're going to see that now the median age is 78 years, and I would say there are lots and lots and lots of patients on a daily and weekly basis who are way above 80. Now, somehow in contrast with some of the data that have been published in the US about 10 years ago, and again, based on a more specific and limited series, we addressed this a couple of years ago as whether yes or no, if you select right the patient and you submit them to radical cystectomy for a good indication, whether yes or no, this will impact survival. And basically, although there was a trend, there's no doubt that there is a trend, it didn't reach statistical significance. Could be that if it was a larger series, it could. Now, what we all found after many, many years, and running, as I said, a multidisciplinary bladder cancer clinic with specific teams of urologists, medical oncologists, radiation oncologists, week after week, what we found is that basically what matters, whether we like it or not, is the fact that the surgeons who will do the surgery are actually very, not only skilled, because even if you've done a fellowship and you do a lot of cases, but whether you're bladder cancer focused. And this was completely independently reviewed by one of our residents, irrespective of the surgeons. The surgeons were completely blinded. And believe it or not, it really happened that in terms of survival, the three surgeons that were the bladder cancer surgeons, truly, clearly, when you match for stage grade, every single parameter, there is a difference. I know that not everybody likes to hear that, but I think the bottom line is that we probably, especially in this patient population, these people should be dealt with highly specialized teams where everything is on par, from anesthesia, from post-op, from nursing, from pre-op. And I personally, and some of my colleagues too, I'm a big fan of the really mini incisions. The umbilicus is way farther up for bladder cancer, and many fellows have come, as you know, to Toronto, and where this is the post-op of, and especially I do it in elderly patients, because for me, a patient who's walking in the hallway, day post-op 1 of a cystectomy, is a patient where the likelihood of having side effects is minimal from DVT, from bowel function, and you name it. One thing, and Fiona mentioned that, I think it's something really important. We've seen many patients who are depressed after surgery over the age of 80. I think it's something which would be worth investigating further. We see these people, and they really have a kind of depression, and very often we have to involve geriatrics, although initially they're really good. Most of the time, except one, they recover, but it may take some time. So the bottom line is that cystectomy in the elderly, and I would place personally elderly now in the very late 80s, if not even 90. I know it sounds crazy, but that's what I really nowadays would say. An elderly patient is 88, 90. There are no difference according to age. The physiological age is by far more important than the stated age, and I really, really think that we need to have highly specialized teams dealing with bladder cancer, and in particular, in the elderly. Thank you.
Alex, in your series, was there, what criteria did you use for selection? Or if a patient was a surgical candidate, you operated on everybody, and how did you determine that?
Again, you know, this is a retrospective study analyzing with all the biases. So there are, of course, inherent biases, and one patient will be selected by one surgeon, turned down by one anesthetist. By far and large, these would be patients who passed the PAU, who passed the pre-anesthesia, and who were absolutely completely accepting. I have to say that more and more, we even do a lot of post-rad failure cystectomies in people who are over 80. What was unthinkable many years ago is something which is very acceptable.
And did their golf scores improve or stay the same, or?
Actually, I should say, it is astonishing to see how people recover. However, I think we have to be fair as well. A surgery in an elderly requires more manpower, and from time to time, there's very limited room for complications. If there is a complication, usually it becomes a life-threatening complication, which would be different from patients who are younger. That's really, for me, the tiebreaker.
Alex, do you change your template for lymph node dissection in elderly?
Sorry?
Do you change your template, your approach to lymph node dissection in elderly?
I think, honestly, most likely, yes. Because I think, let's face it, if you have a patient who's elderly and then you see nothing or there's something, we all will tend to balance benefit and surgery. So I think, although we would tend to say, oh, no, I do the same, I think that's not true. I think we tailor it.
Thank you, Dr. Zlotta. Next is our Israeli delegate for this discussion, Dr. Ilan Leibovitch.
Good afternoon. Okay, so about the definition of elderly, this is the age definition which is most common in the literature, and above 65. And age is a risk factor for bladder cancer. It's a well-known fact. And below and above 65, the incidence is increasing by 11-folds. Age is also a risk factor for invasive bladder cancer, which is more common in the elderly. Regarding the management, well, there are a lot of guidelines about management of bladder cancer. None of them are specific for the elderly, and we just use the guidelines that we use for younger people, also for the elderly. Although there are some differences, which first of all, the concept of the rule of 10 years life expectancy to justify curative treatment does not generally accepted in invasive bladder cancer. We also know that older patients are sicker patients, and comorbidity equals increased risk, more complication, and poorer outcome. So it is that elderly patients had significantly higher prevalence of concomitant disease. It makes sense and it's true. And statistically, they also have more complications, but still it is reasonably safe and essential because even old people or in the elderly people and sicker people also die from bladder cancer and not from other causes of death, even if they're old or sick. So about bladder cancer in Israel. This is the data from the National Cancer Registry in Israel of 2010, divided by age group, and we see that most patients are considered elderly by the age criteria. It's about 2 times more common in the elderly group. And altogether, if we speak about the the rate of non-invasive, of muscle invasive versus non-muscle invasive, which is about 30% of the patient, we speak about more than 300 patients, elderly patients with invasive bladder cancer in Israel every year. So I use 2 databases, one from my department in Meir Hospital, and one was given to me from Sheba Medical Center. And I'm grateful to Dr. Zohar Dotan who gave me this database. And this is a database from Meir. It's the recent database, 98 cases, last cases that underwent radical cystectomy. The mean age was 72, median 74, but you can see that the oldest patient was 90 years old. 76% of the patients in this database were considered elderly, meaning older than 65, and 46% of them were older than 75 years old. The other database from Sheba Medical Center, it's an older database, not a recent one. The last update was done in 2005. The mean age was 67, median 68. 62% were considered elderly. 28% of the cystectomy patients in the Sheba database were older than 75 years old. about selection of urinary diversion in elderly patients, ileal conduit or some kind of continent diversion, mainly neobladder. This is data from the United States from 2011 that shows that people that are older people have very low chances to get a continent diversion, and most of them will get an ileal conduit as a method of urinary diversion. What happened in Israel? This is a database from Sheba, and we can see that the elderly group, only a fifth of the patient, 21%, had a continent diversion, while in the younger group, about 64%, 65% had a continent diversion. The mean age among the continent diversion was only 57 in comparison to ileal conduit that was 71. If we look at the type of diversion above 75 years old patients, then the patient older than 75, only 6% of the patients, 7 patients out of 110 patients had a continent diversion, and basically most of the patients had ileal conduit. This is a different database also from Sheba, a more recent one. All these patients in this database underwent continent diversion. Most of them had neobladder, orthotopic neobladders. 34%, only about a third of the patients were considered elderly in this group, but only 4% of the patients in this group of continent diversion were 75 years old or older. So this is the question if it is justified to put an age limit on using orthotopic neobladders versus ileal conduit. The only reason is the functional outcome, which is better in younger patients, mainly about incontinence, and more common in the older patients. So the conclusion is, at least for the 2 hospitals that I'm really familiar with, Sheba and Meir, we offer aggressive therapy for elderly patients with bladder cancer, and when it's feasible, justified in any age. And I just want to conclude with a verse from the book of Passon about the approach to old people. It says, "Do not cast me away when I'm old, do not forsake me when my strength is gone." And actually what King David said in this verse is, when I have invasive bladder cancer, please operate on me and don't give me palliation. Thank you very much.
Yeah, thank you very much.